Welcome to the Health Matters program produced by the Ministry of Health. I'm your host, Alicia Martin. Today we'll be talking about speech and language therapy. Joining me on the program are Ms. Sonia Fredericks and Ms. Carrie-Ann Richards.
Thank you for joining me on the program today, Ms. Fredericks.
It's nice to be here. Presently in Guyana, we only have 11 speech and language therapists serving the entire country. And 10 of these speech and language therapists are in Georgetown. So that means all the other regions do not have a speech and language therapist, but they do rely on the rehabilitation assistants who have been doing the job in the regions. But of course, we do need a profession. And to build a stronger foundation, this is where we have to start. We need more human resource.
For this program that the University of Guyana is offering, what does it entail? What can persons expect as they think or begin to pursue this field of study?
So the great thing about this program, it's a two-in-one. So it's called the Speech and Language Therapy and Audiology program. And it falls under the School of Medicine. And just as I said with the name, what is great is that from branching off when you finish your studies, you can either practice as an audiologist or as a speech and language therapist. But the key thing is that you have both. And the program was designed by the American Speech and Hearing Association. This is an association in the US. And they saw it as to build stronger that we could have two professions from one program. So if you do want to become an audiologist, this is the program to join. If you do want to become a speech language therapist, definitely. And of course, you will be employed in whichever field you do prefer. I mean, for us in the speech and language therapy, we're repping for our more speech and language therapists, but also we do understand and know the need that the audiology field too. They do need more staff. So when you do enter this profession, it's not, as you see, our room is more child-friendly. It isn't all about children. Sometimes when everyone thinks about speech language therapists, they think, oh, those are the young ladies who help the little children to talk. No, I would like you to know we also work with adults. We work with patients who have had a stroke and their speech have been affected. We help those persons. We work with persons who have swallowing and feeding problems, and this could be both children and adults. I mainly work in this area presently. So in a hospital setting where those patients are ill and because of their illness, they're having feeding problems or swallowing problems. We're the persons who can help them. We can do tests and then we can use techniques to help them get back in that process. So it's a wide field. It's not just with the children, it's adults, it's in the hospital setting, it's also in the school setting. So basically, because we are limited in our human resource, we haven't been able to play that role in the school setting. But if you go overseas in the US and so on, you would see that most of the speech therapists are in the school setting. Where are the children? Who needs us? So where else to go? In the school setting. So indeed, we would like to expand our field again so that we can introduce that system too, where you can go into a school and there's a speech language therapist to assist the children. And of course, in the audiology, it's all about the hearing, testing. But when you become an audiologist, it's not just the testing, it's the treatment of ear diseases too, and specific ear diseases. They have special techniques to help it and so on. So really interesting field. And of course, again, both fields work in different settings and they work with different age group population.
Yes. What is the requirement to get enrolled in such a field?
So at the University of Guyana, they're asking for 5 CXC subjects, a must of English, maths, and a science subject. And the English, maths, and science subject must be between grade 1 to 3. If you're an older person applying, I think they do have where they ask you to write an entrance exam. I think if you're over the age of 26, there's an entrance exam that they have that you would have to write, and you have to pass over 60%. Also for persons who are in the health field, so a pharmacist, a rehabilitation assistant, X-ray technician. We are all Ministry of Health trained certificates program. If those persons are thinking also to switch and join speech therapy, your certificate program helps you to get into the University of Guyana along with 3 years experience in the health sector. So there are a lot of ways, pros and cons, that can help others who just want to get in. Teachers, for sure. Their teacher certificate will assist them to get in to the program at University of Guyana. And we are encouraging some teachers to join our profession. They love working with children. This is another field where you get the opportunity to do a little bit more with children.
Awesome. From what age may children experience these difficulties in speech?
So we have from age 1, we would say. So when we do look at the milestone charts, a lot of times they're looking at if the child is walking, if they're sitting up, if they're holding their head up and so on. But also we got to look at the speech part. So of course, did the baby coo at 6 months, 3 months? Did you hear the baby making these cooing songs? Simple expressions are also, so we talk about speech, but there's also language. So your ability to, when mommy smile, you smile back. So that's language. It starts that early with language. When mommy leaves the room, you recognize that mommy leaves the room. So that's language again. So those little testing that we would ask parents to do just to make sure that this child is on par, their eye contact is there, and so on. By age 1, if your child is not saying anything, cooing songs, no kind of sound, please reach out to us. That child might be delayed and may need our help. Sometimes some parents say, all right, I'm going to give them to age 2. I do give age 2 the limit, that if at age 2 your child is not saying, please mommy, bye mommy, want chips, they're not using basic little sentences, of course that child will need some speech therapy. If that child at 2 is just now start saying back, vroom vroom, and that is more in the age 1, again, bring that child so that we can assess them. Sometimes it's just some advice we need to give you, and you work with the child at home.
These are some really important pointers for parents for them to look for at a very early stage. Are there any risk factors that may contribute to children developing challenges in speech and language?
Yes, so we do have a great collaboration with the developmental clinic at Georgetown Public Hospital here. So developmental clinic normally have those children that had complications during the birthing process, or mommy had difficulty with pregnancy. So of course, these are children that we keep a closer eye on to make sure that the milestones are on par with their age. So if these children, so with the developmental clinic, what they do is that all these children are sent so that we can assess and be sure that, yes, everything is okay and so on. So some risk factors would definitely be if mom had complications at birth, if baby was ill when they were born and had a long time being incubated and was in hospital, if the child gets seizures at a very young age. You do find that a lot of our children, when they do get a seizures, they get a little delay. And just in general, so most of our children, we would say there's no cause. Everything was good. Pregnancy was good. Child was healthy, but then still we see a problem. So we still have that big question mark of what happened that caused this.
And again, I know it's very important for us to continue to improve ourselves so we can better deliver our services to patients and those persons in need of it. For those persons who are listening and viewing this program, do you have any words of advice to them? If they may have a family member who may have a speech impediment or maybe struggling here and there, even a younger child or a sibling, any form of encouragement you have for them or recommendations?
Okay, so basically we're a walk-in system. We do not demand that you have a referral or you have to see a doctor before or so on. We're the specialists to diagnose what exactly is wrong with your speech or language. So the doctor can say, yes, this patient have a delay, but we still have to say what type of delay and the level of that delay. So we do not fight it to have a referral. So basically, you can just call us 225-3294. That's our main department number. And you just call and you ask to speak to the speech and language therapist or the speech department. Just let them connect you. And you can, from there, you explain to us what's happening on the phone and we can book that appointment for you. Of course, because we have several departments and depending on your problem, that will determine which department we will send you to. At this department, we only see adults with voice problem. So if you're an adult with a neurological problem, like you've had a stroke or so, we would see them at the PAMS on Brickdam or rehab department. If the children present with autism, Down syndrome, or cerebral palsy, we see them at the Tolmer Reed Center. So again, at this department, Georgetown Public Hospital, we see voice patients, patients who had a tracheostomy or they had thyroidectomy, and the children who are developmental delay, articulation problems, or stuttering problems. So again, depending on your problem, that's the department we will direct you to. But you call the main department and we will direct you where you will go.
Thank you so much, Ms. Fredericks. Down syndrome continues to be the most common chromosomal disorder. According to the Center for Disease Control, CDC, about 600 babies are born with Down syndrome each year, which is about 1 in every 700 babies born. Down syndrome is a condition in which a child is born with an extra copy of their 21st chromosome, hence its other name trisomy 21. This causes physical and mental developmental delays and disabilities.
So Down syndrome is when there's an extra chromosome in the body. So the extra chromosome is what would cause all the different alterations in presentation of a child or a person with Down syndrome. When you see someone with Down syndrome, they typically don't look similar to you and I. So they have different changes that you can notice. It's generally there's a change in the size. They're usually shorter than normal. They have alterations in the eyes. The eyes would slant upward. They have reduced muscle tone. Some of them can function, high functioning, and so they function. There's alteration in their mental and physical capacities as well.
In all cases of reproduction, both parents pass their genes on to the child. These genes are carried in chromosomes. When the baby's cells develop, each is supposed to receive 23 pairs of chromosomes for 46 chromosomes total. Half of the chromosomes is from the mother and half are from the father. There are 3 types of Down syndrome, which comprise of trisomy 21, translocation Down syndrome, and mosaic Down syndrome. People often can't tell the difference between each type without looking at the chromosomes because the physical features and behaviors are similar. In Guyana, the most prevalent type of Down syndrome is trisomy. To date, the Ministry of Health continues to provide services for both parents and children where they can learn more about the disease and have equal opportunities for learning and playing. We will now hear from a parent who has been given the opportunity to partake in activities and care for her child through the Tolmer Reed Rehabilitation Center.
So diagnosis for kids with Down syndrome, especially in Guyana, is things have changed. Zachary is 5, so I will say that diagnosis now is different from it was 5 years ago. And so in saying that, it means the diagnosis 5 years ago is different from it was 10 years ago. But for Zachary, it was different. He was fortunate, or I was fortunate, to be able to have a healthcare provider who was very kind in doing that diagnosis. Not all parents benefit, in my experience, from our group that we have, that they have the same experiences. The healthcare provider was very kind. You had a social worker present, you had a midwife present, you had a gynecologist present. And so from the inception, you have a full support base, and I think that is what is needed. For a mom, especially if you're a first-time mom, or a mom who's going to receive a diagnosis. So he was diagnosed by sticking of the tongue at birth. My experience with that diagnosis was very, very kind. oftentimes what you will find is not the same thing based on your healthcare provider. Imagine what needs to be done is to ensure that persons exercise a lot of sensitivity to parents, especially in Guyana, where information flow is not so much out there, and so it's important because parents after that go through the phase of acceptance, right? And in that process of acceptance, it means that you have to really accept you have a child, accept the responsibility, and what comes next after that. You have to make that decision because as soon as you accept, it means that you're thinking about therapy. Fortunately, we've seen, again, a lot more advances in therapy in Guyana. I've seen a lot more than what was present, and in my experience talking to parents who have kids who are 30 years old, 25 years old, who have not had those experiences. You have had now, we have more physiotherapists, we have more speech therapists, as much, not enough, not sufficient, but they're there. Occupational therapy, I'm grateful to Talmareed, for example. Talmareed has been very, very helpful with speech, with walking, and I think importantly for parents with kids with Down syndrome is to start with early intervention. Now, I'd like to say kids with Down syndrome are on spectrum, because you have some kids who have mild Down syndrome, and then you have some with the extreme with the healthcare. So you want to be able to do that assessment. Talmareed is like the best place to be able to do that, and being able to know where you're going forward from there.
While the causes of Down syndrome are unknown, there are cases where it can be a genetic condition, along with cases of older mothers are more likely to have a baby affected by Down syndrome than younger mothers. In other words, the prevalence of Down syndrome increases as the mother's age increases. To estimate the prevalence of Down syndrome, the number of pregnancy affected by this condition is compared to the total number of live births.
Even though the actual cause of Down syndrome is unknown, some of the causes, advanced maternal age would play a factor. Even though when we say advanced maternal age, these are mothers at an advanced age. However, this does not 100% mean that your child will have Down syndrome because you're of an advanced age, because we do have materials that support persons, mothers under 35 years of age that have children with Down syndrome. So the cause is not a fixed cause. There isn't a particular reason that someone is born with Down syndrome. The cause is still unknown, but these are just some of the factors that could cause Down syndrome. There are still some researches that are being done to see if environmental causes also affect that, but those have been inconclusive so far.
In addition, there are a few mechanisms that can be used to screen for Down syndrome.
Screening can be done for detection of Down syndrome, but the screening are not 100% accurate. So you can do ultrasounds, you can do blood tests to check on the alterations, and that would be a way. So once a child is born, generally you can tell because of the physical alterations that child would have. You can see it in their facial structures, in their muscle tones, and as a child develops, some of these alterations become more pronounced.
Moreover, early intervention for infants and children with Down syndrome can make a major difference in improving their quality of life. Each child with Down syndrome is unique, and treatment will depend on individual needs. In treating and caring for these needs, 3 therapies can be done. Physical therapy, also known as physiotherapy, has proven to be an essential part of the efficient management of children with Down syndrome through movement and exercise manual therapy. Some common issues that physiotherapists address are delayed developmental milestones, balance issue, and decreased strength. Occupational therapy helps Down syndrome patients master skills for independence through self-care like feeding and dressing fine, and gross motor skills, school performance, play, and leisure activities. Speech therapy works in pre-verbal skills such as eye contact, turn talking, and attention. The speech and language therapist will also work on early vocabulary and language concepts. This can help support the child's verbal and nonverbal communication, as well as their language and cognitive development. Further, the Talmareed Rehabilitation Center does not only provide services for children with Down syndrome, but they also provide a comprehensive service that caters for pediatric disability patients, patients that have disability disabilities and amputees. So if you or anyone you know have a disability, visit the Tullamore Reid Rehabilitation Center for further information.
Ms. Richards, I know that you focus primarily on autism, and so you deal with patients who have this condition. Could you tell us about that, what autism is and what it's like working with such patients?
Sure, no problem. So, autism is a neurological condition, or we would say a neurodevelopmental condition, and there is no cause for it. There is no, I shouldn't say there's no cause, there's no cure for it. But the causes so far, what we've seen over the past 3 years, in the US, they would have done an evidence based research to see what actually is the reason for children being autistic or being on the spectrum. So they would have find that if the parents are older in age, if they're very young in age, if they're exposed to any form of chemicals, so if they live near a factory, any mercuries in the air they're breathing in, if the father works like in a mechanic shop, where he's exposed to a lot of gas fumes, if the mother been taking any form of medication that may lead to the child being on the spectrum. But here in Guyana, we're still a bit puzzled because we're seeing doctors who have children on the spectrum, lawyers who have children on the spectrum, teachers who have children on the spectrum, older persons coming with children on the spectrum, very young mothers coming with children on the spectrum. So, like I said, there is no cure, but we're still trying to find out what is actually happening, especially in Guyana here.
Okay, what happens when a parent or guardian brings your child to the facility to begin therapy? What is the process like?
All right, so our clinic is a walk-in clinic, but what we're trying to get right now is a referral system from the health center or any pediatric doctor to actually give a diagnosis for autism. In Guyana, we cannot do such because you have to get a multidisciplinary group of persons to get it done. So we need a neurologist, a psychiatrist, a psychologist, the pediatric doctor, the nurse, anybody who's in care of this child needs to come together and do an full evaluation. So we go by clinical signs and symptoms of autism or characteristics of. So if we see red flags like the child is stemming, meaning that they're playing with their fingers in front of their eyes, or they're spinning around in a circle, or they're looking at bright lights, they like to see the fan spinning, or they would just stare directly at the light in the roof. Anything with bright colors, they would walk on their toes. Once we see a toe walker, we're like, yeah, you got something going on with you. Also, if the child climbs up a lot, so we're trying to put ADHD and autism in the same category, but we cannot because one is an attention deficit hyperactivity disorder and the other one is a neurodevelopmental disorder. So even if the child climbs up and they can't stay one place, all of that we characterize as, this child may have some amount of characteristics or signs and symptoms of. So in our clinic, we basically look at their speech, language, and behavioral problem and not the condition. So we work with the child with whatever problem they have. So if they come and they're not speaking, we work with the verbal aspect. If they come and they are speaking and their language is a little delay, meaning like we can ask them, how was your day? And they're like, this is a red ball, right? We would work on them like, okay, we need to work on WH questions because maybe you don't understand what we're trying to ask you. Or if mommy asks, how was your day? And they're talking about some other thing or singing a song or humming. We want, because parents come to us because they want the child to have that interaction with them and converse at that level.
Okay, thank you, Ms. Richards. What are some of the routines that you go through in your sessions with patients?
All right, so one major thing that we have in our clinic is structure. And the reason why we need the structure is because if we don't, it's going to be chaotic. One thing we must remind persons is that persons who are autistic or on the autism spectrum, their life is on a routine, and we can't expect them to come into our chaotic world. We need to go into theirs. So one thing that we do, all the children know when they come into the clinic, the first thing they must do is take their shoes off and wait. So we're trying to teach them, especially the new ones, good waiting. Good waiting means it's not your turn as yet, it's somebody else's turn. So when your turn reach, we can get into the room, we're going to sit, then we're going to do our activity. Another great aspect is sitting time, because they're so hyper and they need to get up. They can't stay one place. We try to target sitting time at least 1 minute. So if the child can sit for 1 minute, we know that they can sit for half of an hour. So after the sitting time is done, or we've accomplished that, we go into different activities. So we would do like puzzles, we would do shape, numbers, just to see how much they know. If we see that the child is a high functioning autistic child, meaning that they can go through numbers, colors, puzzles, everything, we move on to the language aspect, because maybe their speech isn't affected, but the language may be.
How do children usually respond to the sessions and the routines?
All right, so at first they would cry. Like the first 3 sessions, they would cry a lot because it's new to them. They're not accustomed to one-on-one attention, especially if they're not going to school. So after that, it's like they already know. When I come in here, I take off my shoes, I go open the door, I sit, I wait on teacher to come, because we would call ourselves teacher. That's the only way, that we are gonna get that high respect from them. So they wait until teacher comes, and then we like, okay, we're going to start with this. When we're finished, we also tell them all done. So when they hear all done, it's a new activity. When we're finished with our entire session, we would tell them, okay, we're finished for the day. Let's go to mommy, let's go to daddy, so they know that they can come out of the room. Session is over.
Great. What can parents or guardians do to help patients who are autistic?
All right, so for a child who's autistic, it is hard on the parents and the guardian. And because, like I said earlier, we do not know what's actually causing it here in Guyana, parents are not educated enough on how to deal with children on the spectrum. So, one thing that we advocate for at a very young age is, if you start seeing signs, you can start seeing signs as early as 6 months. But if you want to be sure, if the child has a regression between 1 and 3 years in their speech, we already know, okay, this child is showing signs and symptoms of being on the spectrum. We would recommend schooling very early. Like, we do not want to send them to a daycare, but it's better for them to go to a play group where they're actually doing functional stuff. So they're going to put on their little uniform with the boots and the socks and the bag. So we know that structure already. They know, when I get on this formal clothes, it's for me to go here. That's one thing that we advocate to parents from the inception. If they come and the child is not going to school, we would say, I think you should get them into school. It's going to help them, right? And we've seen a lot of progress so far with that bit of advice that we would have given them, because in my clinic we have over 200 children, almost 300 now. Yeah, 300 children that may be on the spectrum. That's how wide it is. And all of this happened after the pandemic, because it was no social communication with the outside world, one, and parents love to give children tablets and phones and television. And that's a one-way communication. There's nobody talking back at them. They're just watching this screen, and they're not getting to develop their peripheral vision. So their vision is actually this much. They can't see anything at the side of them. So one thing we don't do at all, parents, is recommend the tablet, the TV, near the phone. Right? So after COVID, we've seen a lot of children came with behavioral issues, and it's hard for them to interact socially outside of home, outside of mommy, outside of daddy. Then we have those who have separation anxiety, so they can't go nowhere without mommy or daddy. So even if daddy leaves them for 2 seconds, they would cry, they would become so frustrated, so miserable, like they don't know what to do. So with those children, that's why we force them into school very early, so that they can get away from that closeness with the family member, because it's the only two persons that they may have known during that time.
Thank you for staying tuned. I'm Alicia Martin saying goodbye for now.